assume Neil's still working out those energy savings, Stephen. Did you have a nice holiday, Joe?
Yeah, it seems very distant already. Thank you, Chair, but it was nice.
Good. Okay, ladies and gentlemen, we'll get going now. Welcome to this, the September Board of Worcestershire Acute Hospitals. This is World Suicide Prevention Day, and for any families who have been affected by suicide of a loved one, it is the most devastating of issues. And for people who maybe are watching this live stream, who maybe are feeling a bit of a state of despair, I'd point out that there are different routes available to you in Worcestershire for you to reach out to. Mind is available between 9 and 6 on weekdays on 0300 102 1234. The Samaritans, which is an absolutely wonderful organisation, and I know a number of people who volunteer on that, do quite extraordinary work, are always open 24/7 on 116 123. The campaign against living miserably is open from 5 to midnight on 0800 58 58 58. And if you're under 25 and you want to reach out to someone, the mix is available via text on 85258, and that's always open. Never feel as though you're alone. The NHS is there to help you. Today is World Suicide Prevention Day. And a simple word of kindness or saying hello to someone when they're in a particular state of need can make all the difference. So without further ado, we have apologies from Glenn Burley, Justine Jeffrey, Jules and Catherine Driscoll, but I think everyone is ready and raring to go. We've had a very interesting board workshop session this morning. Ali and her team and all of the execs have been leading a great piece of work on trust values, where over 500 of our colleagues have been involved in helping to develop from the ground up a set of enduring and sustainable trust values, which is in progress. That's a really exciting piece of work. We then had a patient story about the way our multidisciplinary teams work and sometimes don't work. So we're taking forward the learnings on that. So thank you, Robert and Mark, for presenting that to us. And then, as a number of members of the public are aware, Worcestershire, the Worcester site is a PFI site. The PFIs, and we were one of the early ones, did have the advantage of providing wonderful new facilities for our citizens, but at an enormous level of complexity and cost. So we're only about 9 years away now from ending our PFI. So the board are doing the preparatory work to ensure that that process goes as well as possible. So a busy day already, but without further ado, we'll get into any new declarations of interest or coming out. First of all, Simon?
Yes, Chair, just to declare a new interest. You'll recall I contacted you a little while ago. I was approached by the strategic lead for the Worcestershire Alliance that represents many of the charities in the county to just give them some support and advice as they look to better understand how the NHS works. It's a pro bono post. It's very informal and sort of unofficial, if you like, but I just wanted to make sure that colleagues were aware that I'm now acting in that role.
Super. Thank you, Simon. And Colin?
Yes, Chair, a new declaration of interest on my part. I've now been formally confirmed as an Associate Non-Executive Director with the Herefordshire and Worcestershire Health and Care Trust.
I think that's fantastic, Colin. Congratulations. We're delighted you're sort of working across the two trusts at the moment. It's part of the real focus that we need as a system to work as system colleagues and partners, and I think you'll play a great part in doing that. So
thank you,
Colin. Anything else, colleagues? Okay, we'll move on to the minutes of the board meeting held on the 23rd of July. Did any colleagues have points of accuracy on those minutes? Okay, I'll take them as accurate. And in a somewhat a strange way, there are no matters arising. Quite extraordinary. So we'll pick up on a variety of points, I'm sure, as we go along. And then we had the 4 board foundation group board meeting on the 7th of August. For members of the public, that's every 3 months we bring together the 4 parts of the foundation group. That's Worcestershire Acute, Wye Valley, South Warwickshire and the George Eliot. And we do more of a comparison of performance and pull out key learnings. It's a different type of board meeting, but it's very interesting, and we do get a number of members of the public along. So if you're interested, the next one I think is in November, he said with hesitation. So I would encourage members of the public to come along to that. So the accuracy of those minutes, if there are any points of accuracy that you wanted to point out, could you please raise a digital hand? Okay, can't see a digital hand raised, so I'll take those as accurate, and the matters arising will go back to that board. So you'll have heard me say that Glenn is taking a well-deserved holiday. So Stephen, you are Glenn Burley for the day. On Glenn's Chief Executive report, what would you care to pull out?
Yeah, thanks. And I realised particularly as I got the script for the 1 year on, I was joining the foundation group. It was going to be like an award ceremony speech, so apologies if it does slightly. But I'll pull out some bits and some highlights first. The first I wanted to pick up was on the floor, which is such a big issue for the trust and has been.
Stephen, yeah. I'm not sure if it's just me. Your microphone doesn't sound great. Are other people having the same problem?
Excellent.
Okay, so I'll go on mute, Stephen. Just try again, see if that works.
Okay. Is that any better?
It's not ideal, Stephen. So obviously you haven't paid the electricity bill or the telecommunication bill today. So we'll persevere, Stephen, because I'm not sure what else we can do apart from you dialing in again. But carry on and we'll see how we go.
Yeah, is that any better? Yeah, it might be the connection. I'll carry on. So the first bit I was going to pull out was around floor, and in particular the work we've done around frailty and general medicine with our frailty assessment unit, growing the frailty workforce, and particularly the work we've done around same-day emergency care and re-providing those within the trust, which I think give us a really good bedrock going forward to improve that. The second point I wanted to pull out was around the elective care and planning for no delays, and in particular, reference is made a couple of times to the work that we've done at Kidderminster, and like a big credit to the staff there in terms of accreditation for the hub, but also the basis it's given us, and also for to our teams on the improved cancer performance that we moved out of Tier 1 into Tier 2, which is a bit of a regulation thing for NHS, but what that does mean is that our patients are being seen quicker and better. We're getting better outcomes through that. So that's the important thing to focus on around that. I think a big one that we've spent an awful lot of time discussing and focusing on is around staff experience. Particularly, we're just about to get Park and Ride reintroduced at Worcester Royal, which is such an important issue for the staff in terms of their well-being, and also other things that we've done around building on the kind of developing that real communication with staff is around our executive lives, senior leaders briefing, and a lot of the work that Richard's led from a comms point of view about how we streamline that and how we get messages from colleagues and to colleagues. So I wanted to point out that one. Finally, I think another couple was around the lead provider, and we've started to make some real progress, I think, in the system. I think I lead Place, Worcestershire Place now on behalf of the system, and it's really good to see the representation that we've got in a number of groups. And also, I think for Jules and Julian, the big strides we're making in terms of medical engagement within the system, I think, is a real mark of where we're going, and we're starting to see some real progress on things like virtual ward, integration with partners around that again I think we'll be able to feed back on in the year. And then finally around tertiary partnerships, this is a real group one. I think one of the things with the group model that really gives us a strength is around working with the other trust and the voice that we collectively can have now in particularly working on those complex or fragile pathways with our tertiary partners or between ourselves. And there's a number of examples there where we're working with particularly Y Valley or across the other members of the group to provide more sustainable and better services. Really puts us in really good stead. I referenced the NHS constitutional standards, or Glenn does. There's a real focus with the new government in particular around getting back to that 4-hour UEC performance over the course of the Parliament. And also there's a real focus within the elective referrals to treatment times, not just focusing on those long waits now, but getting back to an 18-week position and how we manage the whole patient's waiting list. So I wanted to pull out. And I've mentioned Kidderminster. There's 2 real successes at Kidderminster. I've mentioned the surgical hub, but the other one is around the JAG accreditation. And I think it was interesting. I did HOSC yesterday, and there was a lot of discussion about what services were happening at which hospital. That was in terms of urgent care, but actually, I think there's a communication job we need to keep doing with the population. That Kidderminster is a real powerhouse now for our elective work, and we're looking to do more and more through there. It's not just a resource for that population; it's a proper resource now for the whole of Worcestershire. And I think there's something. It just struck me there's something for us to focus on there. So that's just what I wanted to pull out. I'm so happy to take any questions.
Thank you, Stephen. Very comprehensive. Any questions or perspective on Glenn's report from colleagues? I do think the point you make, Stephen, about the fact that we are seeing some real traction in terms of improved performance. We'll obviously come on to the integrated performance report next. But members of the public, we do realise we don't get everything right first time. We apologise for that. We are, though, on a very clear improvement journey. We're endeavouring to do the best we can for you as quickly as possible. And your point on Kidderminster is very well made. What we're ensuring is that we, in the portfolio of different sites we have, are able to provide the very best service. That may involve a bit more travel on occasion, and we apologise for that bit, but our desire is for you to be seen as quickly as possible and to the best possible standard with our expert frontline teams. Any other points colleagues want to make? Otherwise, we'll move on to the IPR. Karen?
Just a quick one, thank you, Chair. I'm just linking the 2 points. I mean, it's great news about the park and ride at Worcester. Really looking forward to that. That's going to make a massive impact on a lot of people. I was going to ask also about parking at Kidderminster, and particularly now in light of what you've just said about the increased use of that, because I don't know about others, but every time I go to that site, that's about as challenging as Worcester, to be honest. And I wasn't sure where we were on that.
Yeah, I think, Karen, we've really focused on Worcester because of not just the parking, but the access and the egress, because it's a double whammy on that site. But we are now moving to the others, so we're going to put a car parking strategy around the other 2. We have done a bit of work around diversibility at the Alex. That was another priority for us. So we, funny enough, we've talked about that because I think the assumption is it's a local population, and actually it's increasingly not, because we're bringing people from all over. So we'll get ahead of the game on that one next.
Thank you. Thank you.
Okay, super, thank you. Okay, colleagues, we'll move on then to the integrated performance report. So, Stephen, how are we doing?
So what I tried to do in the summary, actually, because the reports are quite lengthy and there's quite a lot of detail in there. So for this one, I've pulled out on the exec summary kind of the key bits about where we're doing. I think it's fair to say we continue to make progress around cancer in a really good way. That is on a really good trajectory. The elective care against the teams in terms of the really long wait, the focus for us around there is around 65 weeks, and there's still some risk around 200 and the number coming down of patients that might be waiting longer than the 65 weeks at the end of September. So I think that's a focus for us to keep on that one. There's been quite a lot happening around the urgent and emergency care space, as there always is. I think there's a need for us internally. I'm just going to refocus slightly, particularly on 4 hours and particularly on length of stay, because I think we've made some improvements, but I think we're kind of doing that pause, reflect, and are we going hard enough and fast enough on some of it? We've got the issue of the emergency department's floor, which I think is giving us an opportunity to just do that pause and have a real look at it, and particularly around our SDEC provision as well. And also to flag for board, we're in terms of ambulance arrivals, there's new protocols coming in that are looking at 45-minute handovers, which in some periods of the day for us will be quite challenging. So there's quite a lot of work we're doing with system and system partners around what does that look like. But we really want to take it as an opportunity rather than see it as some sort of threat and difficulty. It's a real chance to reset it almost and get us in good shape for winter. So I'll let the individual areas pull through their main bits, but as an overall, that's kind of where I would summarise we're at the minute.
Okay, thank you, Stephen. We'll move into the detail and then we'll come back. Helen Lancaster is off sick at the moment. Chris, very grateful for you stepping up and the hard work you and colleagues are putting into it. What would you care to pull out in terms of our operational performance?
Thanks, Chair. Stephen sort of covered quite a lot of it in his summary, but there's a few bits I would just like to bring the board's attention to. So in particular, handover delays are coming down, so they are on a downward trajectory, as are the number and percentage of patients who are spending more than 12 hours in our department, recognising there's still a long way we want to go in terms of where we want to be, but those are in the right direction. We have got a well-established hospital flow delivery board, as most members of the board will be aware. And as Stephen's alluded to, I think there's an opportunity now to refresh that, to start focusing on our winter initiatives and the things we really need to focus on over the coming months. Winter planning from an urgent and emergency care point of view is well underway, and there's a regional summit today, and we've got good representation from clinical and operational teams attending that. And we will have a winter assurance visit from NHSE, though the date is to be confirmed in that regard. I think it would just be worth highlighting to the board, we are doing the work in the emergency department at Worcester around the ED floor. I know colleagues were aware of the detail, but there is, just to give everybody's assurance, there is a full programme plan in place with mitigations to support that, and that's giving everybody an opportunity to work with system partners to try some new things as part of that in terms of how we're streaming patients and how we're managing patients locally to give everybody the best opportunity. In terms of elective, so July was the first time we managed to have no patients waiting more than 78 weeks for their treatment. So that's a really good milestone for us. It took us longer than we'd wanted it to, but nevertheless, we're on track to maintain that into August and September. 65 weeks, the ambition, as Stephen's alluded to, was for us to be at 0 by the end of September. That is looking challenging at the moment. The teams are still working very hard to see what further mitigations we can put in place, but at the moment that number's likely to be circa 200. Just to give some context to that, at the end of March we had 7,500 patients who we needed to treat by the end of September to have no patients waiting more than 65 weeks by the end of September. So a lot of effort has gone in by the teams in order to deliver that through use of our own internal resource as well as partners around mutual aid from other NHS providers and insourcing. And given we are going to start talking about 18 weeks more and more now, our 18-week performance for July was 59%. It's absolutely not where we want to be, but it's improving month on month from where it has been as part of that journey back towards that constitutional standard. And then just finally, on a cancer point of view, so let's try to find this. So from cancer point of view for July, I think the unvalidated position was just 79% for fast diagnosis standard, but actually the position as of today for July in terms of validated position is over 80%, and that's the best performance we've had in that indicator. And 62 days is over 70% for the first time since June 2022, I think it is. So again, some really good progress being made in cancer overall. And I guess that's not, there's a lots of work going on across the board that's impacting both cancer and elective. We're doing high intensity theatre lists, extended days, lots of initiatives where we're seeing teams work really well together to really push forward in terms of delivering the waiting times we want to for our patients. Stephen's already alluded to hub accreditation at Kidderminster for adults, and more work ongoing with applications in for a paediatric hub accreditation for the same site, as well as accreditation for the Alex as well. So lots to do, but lots of really good stories as well.
Okay, thanks, Chris. Good balance, good summary. Thank you. Colin asks in the chat box, the outpatient transformation clinical engagement is flagged as a risk. Are there any specific concerns there, Chris?
I think it's more about their capacity in terms of their ability and their time to engage rather than a willingness to engage. So we've got good engagement through the Go Further Faster programme with clinicians in almost all specialties now, working with the team locally to really push forward on that. So no specific concerns, but just a general risk around how we maintain the delivery.
Okay, thanks, Chris. Any other questions or perspectives to Chris? Chris, just how many medically fit for discharge patients do we have on an average day?
I don't know off the top of my head, Chair. I'll happily let you know shortly. I'll find out for you.
Okay, if you could, just so that you're aware, I've been doing some calculations in other bits of the foundation group, and the maths is quite extraordinary on the sort of bed blocking of medically fit for discharge. I assume it's between about 30 and 60. But for every medically fit for discharge bed which is permanently effectively blocked because of flow issues and discharge issues, some of the issues will definitely be internal, but the majority of them will be about us being able to flow and discharge patients. If we were able to take that bed and turning it into an elective bed, over the course of the year, every single bed which shifts from being blocked because people are medically fit for discharge to being used for elective inpatient work would make the Trust an extra £100,000 a year in terms of bottom line profit. That's a big number. So freeing up 10 of those beds would add £1 million to our bottom line. It's an enormous opportunity, and Colin, with your new work in in Hereford and Worcester Partnership Trust, the opportunity for us to get the community bed process working and flowing is enormous for us, and it's enormous for the system. It is an abject nonsense that so many people are being held in the most expensive healthcare setting, an acute hospital, compared to the often, particularly if they're medically fit for discharge, better healthcare setting of being at home. Tony, then we'll move on.
Yeah, thanks, Chair. It's a question about cancer 31-day performance. I just want to check whether the graph is correctly presented. It's on page 40 of the pack. It's the lower of the two graphs on that page, and it looks like it's dropped off a cliff edge. I'm just wondering if is that an accurate reporting, or is that just a transcription error? Because it just looks odd to me.
So there's a particular challenge with 31 days in skin cancer, Tony, that's had particularly knock-on impact. I'd have to double check in terms of the scale because I don't think it's dropped that much in terms of the performance, but it has gone down considerably in the month because of the impact of delays in the skin cancer pathway.
Okay, if you can come back to us on that, Chris, that would be good. I assumed it was an error. Okay, Tim, we'll move on to quality and safety. Sarah and Jules, over to you.
Lovely. I'll go first. So the National Healthcare Acquired Infection Targets have very recently been published. And given that we are seeing nationally a rise in C. diff and CPE and other infections, the targets across the country have been increased. So our targets have been increased for C. diff, E. coli, Pseudomonas and Klebsiella. So although we've had an increase in C. difficile last month, we are just 2 cases above trajectory for where we should be with the new standard. However, we're not complacent. Our microbiologists are currently undertaking a deep dive into the reasons for the increase. But to provide reassurance to the board, what we're not seeing are C. difficile outbreaks, and we're not seeing any evidence of transmission from patient to patient. And we've also engaged NHSE support to review our existing C. diff action plan to see whether there is anything that we can strengthen. Our 25-day complaint targets continues to be a challenge, and it still continues to be a challenge due to the backlog within the surgical division. So as at July, we have 60 complaints which breach the 25-day target, and 53 of those sit within surgery. However, we are now beginning to see an improvement. So as of Monday this week, the number of overdue cases was down to 40 in surgery. And as I say, there is a recovery trajectory in place being monitored via their new head of governance. In relation to falls, in July, we did see a significant reduction in the number of falls. However, out of that reduction, we did have falls which cause moderate harm. So we've had no severe harm falls, but as I say, we have had 4 moderate, which is new for us. So there is an in-depth analysis going into whether there's learning out of those falls. Our pressure ulcers, hospital-acquired pressure ulcers, have also increased in July. When we've actually looked back at cases using our PSERF learning framework, they are directly related to the long stays in ED, and unfortunately the long waits that patients are having in their own homes waiting for ambulances, and then the time that they spend outside in ambulances. So we are working with our partners across the foundation group around whether there's anything different that we could be doing from an A&E perspective. We already use reposed mattresses. Unfortunately, given logistics in the department, you can't put patients onto beds and mattresses. You can for 1 or 2 patients, but not when there's 14 in a corridor. And I will stop there and hand over to Jules.
Thank you, Sarah. Jules.
Yeah, thank you, Sarah. Would just like to pull out in support of Sarah's comments about the IPC. So antimicrobial stewardship continues on a pleasing level of compliance. So supporting that cause to reduce our infections within our trust. We also remain with an expected range for our mortality indices, which is also positive and reassuring to us, although we continue to monitor that closely through our DREAMS group on a monthly basis. Just for board's information, which I'm sure the majority will be aware, we're still seeing challenges with regards to our sepsis screening performance, and also with getting our patients who have sustained neck of femur fractures to theatres within our 36 hours time frame. We've obviously been doing quite a lot of work on this over a period of time, and it's become clear that whatever actions we're taking, they don't appear to be the right ones, as we're not making the inroads into either of those areas that we would like. So we're having a complete review of where we are and what we're trying to achieve in those 2 groups to try and identify some actions that should hopefully deliver some improvements. So that work is underway.
Thank you, Jules. Very clear. Questions or perspectives to Sarah or Jules? Tony?
Yeah, thanks, Chair. Jules, I'm glad you made that comment. I'm particularly interested in the sepsis screening. Since when I joined here, been here, 18 months, it seems to be a persistent problem for us, identified as a problem, and yet we've clearly struggled to shift it. So I'm really pleased about what you've said there about the need for a fundamental rethink. But I think it obviously exposes us quite a lot to risk and on a patient safety front, and we've got to have a lot of emphasis on it, surely, because it should be a basic requirement of what we're trying to do. So I just support your efforts to take a different perspective to get it shifted. Thank you.
Thank you, Tony. Any other questions or perspectives? Sarah, I believe I'm correct me if I'm wrong, that a number of our challenges on infection prevention and control are made more complicated quite often by the state of our estate. And I would really encourage our strategic partner on the PFI side to work even more rigorously with us to help us address the estates related issues, which we do pay for through the PFI arrangements, to be resolved as quickly as possible, because they are making the challenges of infection prevention and control arguably unnecessarily more difficult and complicated than they should be. Any other questions to Sarah or Jules? Otherwise, we'll move on to workforce and Ali.
Thank you,
So
Chair.
Ali, over to you.
Thank you. I'll focus firstly on the areas that are of main concern from a workforce perspective, and you won't be surprised that these mirror the conversations we've had at previous boards in terms of temporary staffing spend, particularly around medical agency and those long-term areas of use for medical locums. What we do have now that we haven't had before is specific action plans for each directorate in terms of how they intend to establish better control over agency use and reduce the number of locums in post. Some of those are longer term recruitment plans, so we won't see immediate improvements, but we do have a direction of travel. I dare say that that may not be enough in itself. We are still seeing usage over and above the funded establishment, over and above the vacancies that we have in those areas. We know some of that is around sickness. We know some of that is around increased demand and increased numbers of patients, particularly in urgent care. But again, we do need continued and more in-depth focus on that reduction plan. Our People and Culture Committee will be receiving a report at the beginning of October into this in more detail, where we will look at some of those directorate plans, and we are looking at them at a high level through the finance and performance executive meetings that we hold monthly as well. But needless to say, continued focus is absolutely needed in that area if we're to see the results, because at the moment, whilst the situation isn't getting significantly worse, we're not seeing the improvement that we need in that area. Similarly, we also have some concerns around job planning, which again have been reflected in previous reports. And the reason I group both of these together is because this predominantly is around our medical colleagues. From a job planning perspective, it's all around medical colleagues, and from the temporary staffing perspective, it's skewed in that direction as well. And again, Jules and I are working quite closely on this, and we'll be talking about this in a lot more detail at the next People and Culture Committee, where we'll be looking at what action plans we are putting in place to be able to address the poor job planning compliance, and also address, I think, some historical inconsistencies in the way that job plans have been created and developed with colleagues as well. In terms of other areas of focus, I wanted to highlight again sickness as an ongoing concern, more so the long-term sickness than short-term sickness. Our HR business partners are working closely with directorates to do localised audits and also scrutinise to make sure that the sickness policy is being applied rigorously, and we are having the regular touch points with colleagues to try and get people back to work sooner rather than later and support them to continue in their roles. But I think it's also fair to say we are seeing higher levels of stress and anxiety related sickness than when we benchmark to other organisations as well. So our absence does seem to be more skewed in that direction. We do have a very robust offer around psychological, emotional and occupational health support to people, but those services are under significant strain as well because of the demand on services. So it remains an ongoing area of focus and something we will certainly pick up in more detail as we do some of our longer term values work across the organisation in terms of how do we really support colleagues on a day-to-day basis, not only with the work-based stress, but also we see a lot of people off with home-based anxiety and stress as well, and recognising that we have a duty of care to try and support everybody to remain at work and be well in our employment as well. Couple of areas that I wanted to highlight positively are ongoing progress and compliance with mandatory training. We benchmarked really favourably there, and there's continued hard work to make sure that those stats remain in a positive state. And also from a turnover perspective, again, we benchmark very well compared to our peer organisations there. We do know there are some areas of hotspots and areas that we'll continue to focus on, but across the whole in turnover, we do tend to keep people in our employment, and people enjoy longer term careers with us. Thank you.
Ali, thank you. Thank you for your hard work. And Jules, I know you're working through the hard yards of the job planning. It's incredibly important. And I know you're unearthing a whole bundle of issues, but thank you on behalf of the board for all your efforts. Questions and perspectives, Karen?
Thank you. I wanted to pick up on sickness absence, Ali. In terms of as you rightly said, we've got a very good and a strong offering around the support that's in place. And also, I'm aware through being on the Charitable Funds Committee that we also support quite a lot around the health and wellbeing initiatives and the days. And I've asked through that committee for us to hear more about the impact of that, because it's well and good having these things, but what is the impact? And that'll be interesting to see, and we'll probably see that in a couple of places. But I wanted to pick up, and you slightly touched on this when we talked about the levels of stress and the reporting. Back in there, we reported on ESOS, it was on work stress, which of course covers a multitude of things. And I didn't know if that's what we're still using or
it still is reported as stress and anxiety, which is such a catch-all, really, in terms of definition. What we have done is where we have particular areas of concern, and I'll use Women and Children's Directorate as an example there, sickness for stress and anxiety peaks this year. We have quite a bit of work locally to really get underneath that and talking to individuals, and the recruitment retention lead in that area has been fantastic, working with a HR business partner to really make sure that people are kept in touch with and we understand the reasons for absence. And what we found when we do those deep dives is that it's a really complex picture. People's home needs, domestic arrangements lead to a considerable amount of absence as well. So that stress that's more in society and in people's home lives at the moment is on the increase, as well as work-based stress as well for some individuals. So it's a complex, multifaceted picture, and there's no simple response that leads us to say what the answer is to try and fix this situation. I think we just need to keep plugging away to make sure we understand those hotspot areas and we're supporting appropriately.
Thank you.
Yeah, no, it is an incredibly difficult area because if someone needs to be off for sickness or stress, it's totally understandable, but the burden it places on those staff who are left is enormous. So enormous thanks for those members of staff with very low sickness and absence. Stephen, your hand went up and went down. Was that a mistake?
Yeah. No, I was going to. I suppose it's Ali. Is there a way we can cross-check those? So we did a big section on values this morning, and one of the issues that's come for us is about freedom to speak up, people feeling confident to say things to us. So I guess drawing a conclusion to that one, I guess we need to triangulate that people aren't just describing a home situation because they don't really want to talk to us about the work situation. So I guess it's just a question to pose to you and leave for you to think about.
Yeah,
absolutely.
No, thank you. Okay, we'll move on. We all know this year is an extremely stressed situation for NHS finances, and we are very much affected by that. But Neil, how's the numbers looking after month 4?
Yeah, thank you, Russell. Month 4 has actually been a positive month for us, so we've pretty much held our own in terms of where we had ended month 3. So we got a £500,000 deficit compared to our plan. So it's positive, and it's relatively positive. You'll see from the media there's an awful lot of organisations that at this point in the year have got some significant deficits. So positive at this stage. However, there are a few areas of concern that we just need to keep sighted on, ensure that our focus is on them. So if I strip away, you'll see the large variances in the income and the non-pay expenditure, the operating expenses. If we strip away the pass-through drugs and devices that we get paid for on a spend-by-spend basis, in the main anyway, you'll see that we're underachieving against our elective income target, our ERF, by 1.7 million. So we're not achieving the level of productivity improvement that we'd set ourselves as part of the plan, which, moving towards winter, we do need to focus on that and make sure we try and catch up as much of that as possible and remain focused on it. So meeting with the divisions on a regular basis, we've got weekly tracking of activity and assessed income that we're supporting them with. We've got the flow work stream, there's a theatre work stream, so there's a lot of good work in progress. However, we just need to maintain that visibility and oversight and that traction to try and get ahead of the game before we progress into winter, which of course we know is historically a challenge for elective activity, progressing on plan. Employee expenses looks favourable at this point, but as Ali mentioned earlier, we're not seeing the overall pay bill come down per se. So this is largely offset as a consequence of slippage on developments at this stage. So again, we need to keep focused on whilst our agency is reducing, our bank isn't necessarily reducing, we're still taking on additional staff. So we just need to maintain that focus on that particularly. All of this is currently offset by the fact that we're not insourcing as much activity, and therefore we've got some significant underspend within our operating expenses. They're enabling us to put that report that position as a £500,000 deficit to plan, consistent with last month. So overall, a positive position compared to last month, and certainly compared to other organisations with where we are. Just focus on a couple of other bits if I can, Russell. So productivity and efficiency, we're now at 9.6 million. So again, we're progressing through the maturity of schemes. We've got some focused effort in that area as we progress. Our cost per weighted activity compared to month 3 has improved similarly. So our expenditure is 2% lower than June, and our activity, our weighted activity, is 2% higher than June. So again, seem to be heading in the right direction in that respect. Just wanted to pull out a couple of areas, if I can, in respect of capital. So we've received some additional funds for Kidderminster Treatment Centre in respect of the aerated concrete roofs and infrastructure that is there, £2.7 million, which is fantastic news, and cash. So you'll see that there's 2 or 3 slides in respect of cash, because cash is very much a focus for us right now. So we clearly get cash support to finance the deficit that we planned at the start of the year. However, centrally, that hasn't yet been released to us, so we're having to apply for the cash in order to support payments of creditors and salaries and wages on a month-by-month basis. In order to support that, we're driving down our debtors as much as we possibly can. And you can see the improvement there within slide 39. So overall, a positive position at this stage, Chairman, but moving into to winter, still an awful lot more to do, particularly in respect of the CPIP and the productivity improvement. Happy to take any question.
Thank you, Neil. Well said. I agree with you on the CPIPs, absolutely. Colin?
Yeah, thanks, Chair. On that theme, I welcome the fact that we've made the progress that we have, both cumulatively and in the month. But I noticed that quite a chunk of the improvements made have been non-recurring. So obviously that doesn't impact on our underlying run rate as much as we'd like. So is there a cause for concern there, Neil, or is it just the way the system's working at the moment?
It's a mitigation, Colin, at this stage in terms of any slippage on development of those schemes. We haven't written that many schemes off. So the fact that the schemes are slipping by a month or 2 doesn't mean that we won't, on a full year basis, still deliver those schemes, but we are having to mitigate them on a non-recurrent basis in order to deliver this year's plan. So there's an element of a cause for concern, particularly in respect of why are they slipping, because it's part of our plan to deliver the whole of the 45 million plan, obviously. But out of necessity, we're having to bridge that with some non-recurrent support this financial year. I must say it has improved quite significantly again when you come to review the report for month 5 that we're presently working through. You'll see the maturity of the schemes is increased significantly still. So positive direction, but certainly more to do still.
Yeah, And obviously the FRB, Colin, is our opportunity as a group of non-execs, the Finance Recovery Board, to look in and deep dive into that. Okay, team, thank you, Neil. Thank you for your team and your hard work. We'll move on then. If we can pick up the pace a little bit, guys, because we're just running a little bit late, to the perinatal report. Becky, lovely to see you today. I think it's your first time at the board. Thank you.
It is, yes.
For Justine. Over to you. What would you care to pull out of the report?
Thank you very much. So our workforce KPIs are support worker and care assistant remain an area of focus. However, our sickness is significantly decreased, but we recognise we still have more to do within that area. Our trust training KPIs, again, a focus that we continue is with our PDRs for all the staff in maternity. We recognise that there is an issue with our mandatory training for doctors, but one of the issues that we've identified for that is due to the rotation of those individuals. For our role-specific training, we are currently on trajectory to meet our CNST requirements, which is very positive. For our staffing, in obstetrics, we continue to have an issue in the middle grades because the deanery fill is decreasing, and we will be needing to continue to use locums to maintain a safe service. For midwifery staffing, safe staffing was achieved on all of our shifts in the past month. For neonates, the QIS trained percentage of staff has not always been met, but it has been very close to meeting as required. And there are further staff identified to complete the training, and we're also looking to onboard a nurse who is QIS trained. For our complaints, the current focus is on delayed complaint responses, with a particular area of concern when we've triangulated our complaints, looking at the CQC survey, local intelligence, and the MMVP continues to be the care received on our postnatal ward. Primarily, that looks at delays in medication, attitudes and behaviours of some of the staff, and also our bladder care. So with a view to addressing these, we've introduced drug rounds, or reintroduced, I should say, our drug rounds, taking extra care to ensure that our care and comfort rounds are carried out as they should be. And we've also commenced audits on delivery suite and postnatal ward around bladder care to include fluid balance. We continue to have some delays in our inductions of labour. In the previous report, it was erroneously reported an improvement in the wait time. It was actually noted at 30% and not 13% as recorded. For July, we're looking currently at 38%. For CNST, we've received further information from NHS resolution. That means we will need to change some of the requirements. The quarterly reports are available, and it's likely that be 91% compliance with saving babies' lives for our next ICB review, which is positive, and previously we had achieved 83%. And finally, when we look at our heat map for the region, it's constantly changing because of the requirements of the areas for the scoring, but we are currently green, and further actions noted to improve the position further include looking at our staffing and our CNST compliance. Are there any questions?
Excellent summary, Becky. Thank you. Any questions of Becky? Becky, how many babies do we expect to arrive in September?
Oh, well, we normally would expect to have probably around about 300 this month, but before the end of the meeting, I'll have a quick look on Badgernet and I'll let you know how many we've had to date.
Great. Well, hopefully 300 healthy babies born to bring more joy into the world for those families. Thank you, Becky, for your hard work. Please thank your teams. I will move on then to the safe staffing reports. Sarah and Becky again, what would you care to pull out?
So let's do nursing first. So for July, staffing on paediatrics, neonates and adult inpatient areas all maintain safe levels, and the trust remains compliant with National Quality Board safer staffing recommendations. The annual acuity and dependency reviews with all divisions has now taken place and has been finalised. We've triangulated the acuity data with quality and safety measures, and also a professional judgment and a chief nursing officer confirm and challenge session with all wards. The paper is going to Trust Management Board next week for approval, but there's no additional funding that is required, and there will be CPIP savings within that paper. You will see that we continue to reduce our agency spend and our average hourly rate for agency workers. That continues to remain a focus, and we expect further reductions over the next few months. And we are continuing to see that consistent reduction in tier 3 and tier 4 framework agencies, and we're just using one off framework nurse at the moment to support our occupational health service. And just lastly, just to point the board to our domestic and international nursing recruitment timeline. By the end of this financial year, we expect to just have 31 vacant nurse posts across the trust, and we do expect that to reduce further as our retention continues to improve. And we're really, really pleased to announce that we've just commissioned a new provider, which is a new school of nursing and AHPs that has been providing services for just 18 months, which is New and Birmingham University. We've just commissioned them to provide some additional nursing students to the trust from February, and also Rachel, our director of AHPs, is working with them to look at what trainee therapists we can actually secure for next year in relation to occupational therapists and physios. So I'll stop there.
Fantastic, Sarah. And we'll just segue into the midwifery safe staffing report. Becky, what would you like to pull out?
We have had for our KPIs, our sickness and turnover for midwives has decreased. We've seen a slight increase in turnover for our support workers, but that's due to requirement. But again, sickness has decreased. In terms of any red flags, we've had one-to-one care and supernumerary status achieved, with the exception of one report where the supernumerary status of the coordinator was not achieved throughout the shift, but at the beginning of the shift they were rostered on as being supernumerary. In terms of acuity, we've had the highest levels achieved since our reporting began, possibly due to an increase in the efficiency with which the reports are being completed. We have seen some escalation where we've had to ask our community and continuity colleagues to come in to support, but that is generally reducing. We have a birth rate plus plan to repeat with them in autumn and winter. We've already engaged with the team and expect to complete before the end of the financial year. In terms of incidents, we've had 2 no harm staffing incidents and 7 no harm medication incidents. And in the pipeline, we have 16 whole-time equivalent midwives expected with us by the end of November. And we're also out to advert for maternity care assistants.
Thank you, Becky. Any questions to Sarah or Becky on safe staffing? Fantastic. We've secured 110 of those nurse graduates from Worcester, Sarah. Really encouraging signs of progress. And particularly when we go back to the trust values work that Stephen referred to earlier, it's important for that to become a virtuous circle of people really loving to work at the trust, wanting to work at the trust, being advocates of working at the trust, and then we'll all find ourselves in a much better place. Okay, team, thank you for your hard work. We'll move on then to some items for noting and information. And the first is some verbal updates on meetings that have occurred and some minutes. The first is the Quality Governance Committee. Julie, what would you care to brief us on?
This is July's meeting. We've had August since then, so I think the minutes sum it all up completely. I didn't think there's anything I want to add. Thanks. Okay, and the August meeting was interesting as ever. The quality meetings are always absolutely fascinating, and we get through an awful lot of business and we bring things here. We decide then what needs to come here as a separate thing, but we've covered a lot of it today with the infection control, as Sarah updated before, and the change in targets and things.
Super. Thank you, Julie. Thank you for your hard work. Any questions or perspectives to Julie? And then move on then to the Audit and Assurance Committee. Colin, what would you care to pull out?
The minutes that are in the pack, Chair, are of an extraordinary meeting, which it was extraordinary simply because it was short notice. We convened to receive the final version of the external auditor's findings report, which we weren't able to take at a slightly earlier meeting. And that is the last piece in the complex jigsaw that represents our annual reporting cycle on the accounts and business of the Trust, which was completed in a very tight timetable. So that's all well done to the finance team and to colleagues generally.
Thank you, Colin. Any questions or perspectives to Colin? Erica, just for members of the public, can you remind us when the AGM is, when we'll obviously be doing our review of the last financial year and the various different achievements of that year?
I will do, Chair. Let me just check. I'll confirm in the chat. I'll make sure I don't confuse it with another trust.
Okay, apologies to put you on the spot there. Then the People and Culture Committee. Karen, anything you'd like to pull out?
Yes, thank you. The minutes that you've got there from the 3rd of June meeting, which are as written. We've subsequently had a meeting on the 6th of August. A couple of things I want to pull out. We had a staff story from theatres and we were particularly interested in that. Colleagues may remember that the teams are doing a piece of work particularly on the culture and staff survey results within theatres, so we were keen to hear back the impact that that's having, and it was good to have some members of the team there and speak very openly about their experiences. We've also agreed to do a little bit of review of AACs. For people who don't know, that's Advisory Appointments Committees, where we appoint consultants. There was a refresh, oh gosh, I don't know, 6-9 months ago with non-exec input, and we're going to relook at that again. There's been much improvement, but there's still a couple of things that can be tweaked. And there's further work ongoing in terms of the risks around people, and Ali and her team have done quite a significant amount of work on making sure that they are really described in the way that we'd want to. And the only other thing, last thing I'd want to mention is, it doesn't come up in the papers, but I think it's helpful to mention, is last week we held a presentation for the leadership and apprentices that had completed. Ali and I attended that, and it was great to see. I don't know, there must have been well over 100 that Ali and I presented to, and it was a really good event. I think it's important to note that.
No, thank you, Karen, and thank you for going the extra yard on that. Any questions or perspectives to Karen? Okay, so we'll move on then to the Board Assurance Framework and Risk Report. Sarah, what would you care to emphasise here?
Erica's going to take this paper, Chair, if that's okay.
Of course.
So, Chair, this is just an update of the BAF, which, if I could, just as a reminder, the BAF is the risks to us achieving our strategic objectives. So those risks to us achieving the 10-point plan, and these particular BAF risks are produced in consultation with the chief officers. We have put a direction of travel since the board were last presented with those risks. So that's not saying that these are the Trust's risks. Work is in progress to improve the systems of capturing risks and the so what analysis of what we do with them. And we expect to bring the full the details of the high risk register to board in October, where they can see where it's the more operational risks and those that we're dealing with day to day. Of which Sarah is the lead for risks generally, and I'm just taking questions on the BAF.
Super, thank you. Any questions or perspectives to Erica or Sarah? Ali?
If I could just highlight, Chair, that regarding the BAF risk around culture, we will be reviewing that in its entirety as we approach the launch of new values as well, and refreshing the wording within that risk.
No, super, thank you. Any other questions or perspectives to Erica or Sarah? I think our biggest risk at the moment is the whole financial challenge for the NHS, to be honest. So we wish the new government well in working through the conundrums which they are facing. I think, therefore, colleagues, we're on to any other business. Any other business, please raise a digital hand. Karen.
Thank you, Chair. Completely unrelated to anything we've discussed. I just wanted to raise a query, and I'm not sure if this is Ali or Sarah or who it might be, to be honest. Fully appreciating the challenges of this sort of thing. I'm just interested in the work that may be ongoing around smoking on site. And I raise this because I've particularly noticed it seems to be on the increase, and this is from a patient viewpoint as well as staff smoking in uniform on site, and absolutely appreciate the challenges of such a thing, having been responsible for it myself in other places. So I just wondered where we are with that, if there is any work going on around it.
Ali.
Thank you. There is work going on around this, and I'm delighted that our improvement team are actually now working with me on coordinating this as an improvement project. We are focusing more so on the Worcestershire Royal site. That's where we see the most of the complaints, but we are exploring and testing principles in terms of potential solutions and whether we shouldn't accommodate smokers in areas of the site. Obviously, all of that could change with potential new government legislation as well around smoking on hospital sites, but there is a task force working on options at the moment, and we'll update in due course as that work evolves.
Yeah, I think it is responsible as an anchor institution, probably the largest, if not one of the largest employers in Worcestershire. We do have a responsibility to help our colleagues in terms of their own health and well-being. Smoking is an addiction, and therefore it's easy to say don't smoke, but it's often more difficult, just like alcohol, just like sugar, just like ultra high processed food. So our whole health and well-being strategy needs to help our colleagues overcome that and enjoy longer, happier, healthier lives, which is what we want for everyone. And segueing back to the start of our board meeting when we talked about World Suicide Prevention Day, we are as an employer there to help you. If you need to reach out to us, please do so. We take our responsibilities for you as a colleague and our compassion and kindness to one another very seriously. Any other business, colleagues? What? Becky?
It's just the promised update to say that we've had 130 births so far in
It's looking
September.
like
So,
300 births a month, Becky. So
plus, I should think, yeah. So it's busy.
thank you, and but joyously busy. Nothing better than. It's one of the benefits of being chair is I'm the Ned Safety Champion for maternity at South Warwickshire, and to go around, you see those young babies and the parents in that state of despair as to how they're going to cope. There's joy in their hills. Erica?
Just to, as an update, Chair, the AGM is on the 24th of September at 5:30. It will follow the same format as our public board meetings. So members of the public will be able to join via the streaming service.
You took the words out of my mouth. Thank you very much, Erica. We look forward to seeing you at the next public board. Members of the public, for my colleagues, I suggest we have a short break. We meet again at 2:15 and I'll try and save you some executive time this afternoon. See you at 2:15. Take care, everyone. Bye-bye.